is going to deliver on guest speaker. Let his speech on Sushruta's contribution of Bagandara, especially in the surgical management. And definitely it is a very good concept. What is called Chedya Bagandar. Okay. In this concept, he is going to enlighten this topic. Okay. Continue, Shamadri.
Thank you, sir. Namaste. Good evening, everybody. Once again, I am very thankful to my teacher, my guru, Dr. P. Hemant Kumar sir, and Dr. Hemant Kushikani sir, for giving me another opportunity on this platform, National Sushruta Association, for sharing my views. So today's discussion would be on surgical management of Sushruta's approach. How Sushruta, we say Sushruta was a surgeon, Sushruta was a philosopher, and what philosophy he taught us, what surgical skills he taught us. So that we hardly practice. So in case of Bagandara, he has mentioned different incisions. So how these incisions are adopted at different openings and different presentations of Bagandara, that we shall see today. So to start with, I am thankful to God for giving me birth on this wonderful earth. I am thankful to my parents, my family, my wife and son. And I am thankful to my gurus who taught me. And I am thankful to my students, patients, and today's audience. So, to begin with, uh, Acharya Sushruta has mentioned this is Bagandara among the Ashtamahagatas. This is one of the tough disease and a difficult disease to manage, either medical or surgical. And 100% population suffer from anorectal disorders. Among them, few suffer from Bagandara, and those who suffer from Bagandara, once they get rid of this by the procedure, a single surgery, it is their fate and luck. And if they do not recover, again repeatedly they have to undergo. And so far we have seen the practice advantage of Char Sutra treatment. That is one of the best treatment modality. It's a treatment modality mentioned by Acharya Sushruta in Nadi Runa. Bagandara is one of the Nadi Runa. With this reference, we practice it. I am not going to deal Char Sutra today. So Char Sutra is therapy, is ultimate therapy. I don't deny. But other treatment modalities also Sushruta has mentioned. So that we shall. And Char Karma, see, along with these incisions, when Char Karma is Chedana and Char Karma, Acharya Sushruta has mentioned. So that we adopt. So it would be very easy, beneficial for the practice. And then a role of Anushastra Karma, see Char Karma, Agni Karma, and Rakta Mokshana. So they are said to be the outstanding contribution of Acharya Sushruta. Because a surgical disorder managed without surgery by adopting these procedures. And almost a bloodless surgery is carried out by adopting this. And I consider these parasurgical procedures as excellence of Dhanvantari Parampara. We all belongs to Dhanvantari Parampara, a surgical school of thought. Okay. So in a surgical school of thought, these parasurgical procedures and the Sushruta's technologies or techniques all stands excellence or they excel. So that is why I call them as excellence in the field of Dhanvantari Parampara. So Bagandara is one of the Ashtamahagada. So yes, uh, why no definite treatment it is, in spite of medical advancement. And it's the most prevailing anorectal disorder. Among all the anorectal disorder, it's the most prevailing disorder. So its morbidity is more. Okay, there is no mortality out of this disease, but morbidity is more, and it is headache to the doctor, and it is pathetic to the patient. So most of the time we call, when the cause is not ruled out, it's said to be the idiopathic disease. But I call the idiopathic disease or recurrent disease as idiot to the doctor and pathetic to the patient. So this is what we experience, and yes. So once somebody asked me, do we practice Dayopasre Chikitsa in anorectal disorder or arthritis like that? I told them, yeah, this Dayopasre Chikitsa is something like a counseling and giving assurance and giving courage to the patient. So this is Dayopasre Chikitsa, even if practice or don't practice in anorectal disorder, but a budding surgeon, when he operates the fistula, Bagandara, when that patient comes with a recurrence, so that time Dayopasar Chikitsa is needed for surgeon than the patient. Okay, so uh, it's a best weapon to use against a popular surgeon. Okay, if a surgeon is very popular in your area, you refer a case of fistula, So I think it's the best weapon to use. So why difficulties? What kind of difficulties we come across? So as far as diagnosis is concerned, so clinically you can diagnose a disease. It's very easy. Just by examination, external opening, first discharge, near the anal verge, you can diagnose the disease as a Bagandara. There is no investigations required. But why you face difficulties? Yes. So what is the nature of the tract, whether it is a cryptoanal origin or it's a linear tract, curved tract, branched tract, whether it's high anal, low anal. So to know all these things, it's a difficult. Especially for the beginner, it is really a very difficult. And once you start understanding the anatomy and Goodsal's rule, and then as and how you do the examination, digital examination, you start defining the track. You start defining the track. So in that regards, as far as clinical rectal examination is needed, fistulogram as a investigations as a very basic investigations we used to carry out. So nowadays, fistulogram, even if it reveals the tract, but sometimes spillage of the dye misleads. Spillage of the dye misleads. So that one has to take care. And some of the fistulous tract, curved tracts, branched tracts. So in like Ushtagriva, Shambhukavarta, so that type of Bagandara, it is really very difficult to do surgical procedure. Okay. And probing and threading, what we do. So probing before surgery, please do not do probing. This is my earnest request. So when you do probing, you are likely to create the false tracks. So if you create false track, when you operate, what happens is you operate a main track, and what false track is created, it is left as it is, and it becomes the source, and disease exists. So false track, creating false track, it is iatrogenic, so that leads to recurrence of the disease. And post-operative pain. So again, post-operative, when you cut and suture, so that time really post-operative pain is horrible. Patient cannot tolerate the pain. So when you do some fistula surgery, when there is a pain in the post-operative period, there is something wrong with the procedure. What I say, either you tied the sphincter, or you have used a lot of sutures, or some other problem, or the disease is left there itself, or sometimes the pus locules are not broken and it is left, and the as it is the abscess continues, then it will be very painful. So sepsis and abscess, hygiene. So from all these point of views, we face lot of, not only myself, all proctologists face difficulties with these points. So I directly go to the abscess, because we the disease, the story of or the fairy tale of Bagandara starts with Bagandara Pidika. Okay. So these Bagandara Pidika, anorectal abscess, that you must perianal abscess, hysterectal abscess, submucosal abscess, intrasphincteric abscess, transsphincteric abscess. These are all the types of different types of anorectal abscess we come across. So one must know these things. And if this abscess is not treated properly, if the abscess is not treated properly, then it leads to Bagandara. So that is, we call it as a Nadirana. When Vidradi is not treated properly, then it leads to Nadirana. Like that, here Bagandara Pidika not treated, then it leads to Bagandara. So management, these are the treatment principles. Uh, yes. Harsha, whether slides are visible?
Sir, slides are visible, but in mobile, I think someone is getting to pin the screen. That's
Mm.
why so many students
Now,
are
now
asking.
okay, now okay. Why? Because I think there is another Muhammad Samudri. Then now it is coming.
No, it is coming now, sir.
Now coming,
Okay,
can
sir.
continue, no problem.
Yes. You don't share the slides.
Means
Sir,
you
You
just
don't.
informed
sir,
that.
sir,
Yes, my
technically,
students
technically,
also started. So I
sir,
told them
ऐसा है.
not to. Yes, sir.
हम जिस अकाउंट से शेयर कर रहे हैं उसी
जी.
अकाउंट का अगर माइक ऑन होगा,
हाँ
माइक
हाँ.
उसी उसी अकाउंट का होगा तो पार्टिसिपेंट्स को इजीली विजिबल होगा. अगर हम
Okay.
दो डिवाइस का रखेंगे तो
No,
पार्टिसिपेंट्स को वो पिन नहीं हो पा
you
रहा
typed
है.
that device person actually. You type in the message actually, nothing.
Okay.
No, it is okay,
Yes,
no
yes, sir.
problem.
So, yes, sir. I will begin with the presentation.
ಸಮುದ್ರ
I
ನಿಮ್
continue.
ಲ್ಯಾಪ್ಟಾಪ್ ನಾಗೆ ಪ್ರೆಸೆಂಟ್ ಮಾಡೋ ಶೇರ್ ಮಾಡೋ ಅಂದ್ರೆ ಆಗ್ತದೆ ಈಸಿ.
ಸರ್ ನನ್ನ ಲ್ಯಾಪ್ಟಾಪ್ ಇದು ಇಲ್ಲ ಸರ್, ನಾನು ಇನ್ನೊಬ್ರ ಲ್ಯಾಪ್ಟಾಪ್ನಾಗ ಮಾಡಾಕತ್ತೀನಿ. ನಂದು
ಅಲ್ಲ
ಸ್ವಲ್ಪ
ಅದ್ರಾಗೆ ಶೇರ್ ಮಾಡು,
ಔಟ್
ಎಲ್ಲಿ
ಆಗಿ
ಮಾತಾಡ್ತಿಲ್ಲ ಅಲ್ಲಿ ಶೇರ್ ಮಾಡು.
ಲ್ಯಾಪ್ಟಾಪ್ನಾಗ ಶೇರ್ ಮಾಡತ್ತೀನಿ. ಎಸ್
ನೀನೇ ಮಾಡು ಡೈರೆಕ್ಟ್ ಆಗಿ, ಅಂದ್ರೆ ಕನ್ಫ್ಯೂಷನ್ ಆಗಿಲ್ಲ. ಅದೇನಾಗ್ತೈತಿ
ಸರ್.
ಸಿಸ್ಟಮ್ ನಾಗ ಕಾಣೋದಿಲ್ಲ, ಮೊಬೈಲ್ ನಾಗ ಮೋಸ್ಟ್ಲಿ ಕಾಣೋದು.
Yes, sir. Okay. Yes, different treatment modalities are available. So Kshar Sutra is there, Kshar Karma is there, Agni Karma is there, Chetana, different incisions. So this is the point which I am going to highlight today. Chetana, then followed by Kshar Karma. So that also is there. So these are the last 2 points I am going to discuss today. So when it is a Vidradi, Bagandhara Pidika, what does the text says? Let it be a perianal abscess or a hysterectal abscess. What happens is most dependent part. So what we mark here is the most dependent part. This is the anal verge, and this is the left hysterectal abscess. So I have taken it as an example. So when you point out the most dependent part. So on the most dependent part, you need to take a cruciate incision. We call it as a cruciate. This is what the text says. You have to break, then insert the finger, break the pus locules, and this is how. And sometimes this causes some recurrence, one, and it leaves the ugly scar. Okay, it leaves ugly scar. So this is what the text says. And Bhedana and Visravana. So this is a modified cruciate incision or something like cruciate incision. Same thing. So one example I am taking here. So this is a treated bilateral hysterectal abscess. A lady came with retention of urine. So she was treated for fever and retention of urine, thinking that she is having some this urinary tract infection. So when she was brought, this was her condition. So I asked her whether you passed the stool. She told, 2 days I have not passed the stool. Do you have pain? Yes, there is a lot of pain. I cannot sit. So this history, see, of course, there are different and very costly and very sophisticated investigative tools are available. But equally, history and clinical examination is very, very important. Everybody, first you depend on history and clinical examination, and then go for investigations. This is my sincere request. Don't send blindly for MRI, don't send for CT. So first you do take a history. Why I mentioned history in this patient history was it was not taken properly and they missed the case. So this was her condition. There's a huge bilateral hysterectal abscess. You can see here induration. This is what the induration. So complete. So here I am going to tell you how this is meant. She had a fissure with anterior sentinel tag and anterior fissure. So my dilatation was done. Earlier I used to practice dilatation. Now I have stopped dilatation, practicing of manual anal dilatation. Now it is a absolute practice. So just by dilatation, pus started coming out. So this is a 6 o'clock position. Pus it has internally it has opened and it started draining. But this is not a treatment, complete treatment. So you need to take an incision. Just intrasphincteric groove, you take an incision at skin level. So this incision, I call it as a Langalaka and Ardhalangalaka. So this incision, what I have taken is a Langalaka that I will show you further. At the end, I will show. If time permits, I will show. Vyado tatra bhuchidro bhishajava vai vijanata. Ardhalangalaka langalaka chedaha karyo langalako va api. Langalako api va sarvato badrako api karyo gotirtako api va. So these are the different incisions Acharya SUSHRUTA has mentioned. So here Langalaka. Okay. Langalaka, this is what? This is like a weapon. It is held here and it is pierced. It's a held and Ardhalangalaka is something like so it resembles like this. Okay. Langalaka is bilaterally. We are going. Okay. This incision. So I will show you. Yes. Parshvabhyam chedyo langalako mataha. Dalhana says Langalaka means both the side when you do chedana. So that is Parshvabhyam. Parshvabhyam means both the sides. Parshvadve tu cheda langalako mataha. Vakpata also says it. Both the side you have to. Parshva eko atram eva sa ardhalangalaka. So Dalhana what he says, one side when you take the incision. Okay. So that time it is a ardhalangalaka. So Vakpata also of same opinion. So at skin level I have taken an incision. Then for practical purpose I am showing you how the tissue is visible. Still we have not entered the pus locule. It is an intrasphincteric space we have to enter. So after that you need to do a blunt dissection. Blunt dissection with the sinus forceps. Just you enter, then pus has started coming out. Okay. So once the pus has started, then insert your finger. So the incision is taken at the 6 o'clock position. So you can see my left index finger here. Here till here was the induration, and till here you can see my index finger is going. So total indurated intrasphincteric area that the finger has entered. So then gently you can scrape it out and then do the Sharka. So that also. So another side, here I am using the right index finger. So you can see right hysterectal area. So tip of the finger comes here like this. So after this, do Ksharkarma. When Ksharkarma is done, then it is cleansed, then washed with a lemon. Okay. And then it is dressing is done with Chateti Tela or ST Madhutela. I prefer ST Madhutela and dressing. So this is how post-operative how it resembles. So you see, this is a wound, and all the induration, everything, it is gone. At 6 o'clock, a small wound, and when the wound is, it is healed completely, then there is no scar at all. This is another case I am telling you. It's a full form fistulitis. So here also Langalaka incision was practiced. You see, this is 6 o'clock position, and this is the one fistula opening, and here two fistulas opening. So in the post-operative period, they started drying up. The track is not at all tackled here. Only the source of the fistula is treated. 6 o'clock position, open the incision area, then a Kshar karma was done, and then later they heal. And scar is very negligible, and it heals, and there is no fibrosis also. And you are not cutting the tissue, you are dividing the tissue and put. This is another case I am showing you. So it is here, external opening of this fistula tract here, but it was extending like this. It was extending like this, and 6 o'clock position it was opened, and then Kshar karma was done. Then this is the healing fistula. So now Shambhukavarta here, how this Gotirtaka incision. Okay. Yes. Gotirtaka, here I wanted to tell the commentary because some academicians are also here along with the practitioners and PG scholars. It is very useful for you too. So Gotirtako Gachato Gomutra Gati Sadrshaha. So one, he says, 3 types he has told. Gotirtaka means he has told Goardhako. So that is foot, cow foot's impression. So this is how the impression, cow's foot, impression of a cow's foot. So that is one. And another in Gachato Gomutra Sadrshaha. So when cow walks while urinating, so how that dhara maintains, so it spills out, okay, and it spreads. It spills out and spreads. So then, like that, you have to take an incision. So still, it is a bit difficult to understand initially. And then another one is Athava. What he says is Gotirta go yoni ruchate. So when you take an incision, see, it is very clear here. It is very clear. It looks like a go yoni. Okay, it looks like a go yoni. So anterior fistula it is. So when I took the incision, it is looking like a go yoni. Okay, it was an abscess. Of course, it was an abscess, anterior abscess, and then incision was taken. Then after incision, look exactly, it looks like a go yoni. Okay. So this is how we have to understand and adapt. And this I will show you. See, this is what the Gotirtaka incision was taken. So it was a bilateral, and it was taken both the sides. Okay. So this is Shambhukavarta type of fistula tracts. It is useful. And next comes is Kharjura Patraka. So Kharjura Patrakam Patram Eva Patrakam Yasya Kharjura Patrakam. So branched incision. You can say a branched incision. So this I will show you at the end. This video clipping of this branched incision, you can say. So this branched incision, something like more than a Z-plasty, something like more than a Z-plasty. So Z-plasty, so this is a pilonidal sinus treated. So after Z-plasty, they have done Z-plasty, and after Z-plasty also there was a recurrence. And after that, it was this elliptical incision was taken and Kshar karma was done. So with that, you can see how it is healed. Okay. And after this, I wanted to tell you Sarvato Bhadraka incision. Sarvato Bhadrako va api karyo Gotirtako api va. So he has told Sarvato Bhadraka. Sarvato Bhadraka yatratu sarva disham agachati shastram sa Sarvato Bhadraka. Hindu has commented on this. So from all the directions, you have to take the incisions. So how it is? You can see here incision was taken, and incision was started from here. This you will see how it is, it extends. So this is what there is a big cavitation here on external opening, and here that it is exactly at the intersphincteric groove. We have opened it, and then scooping is carried out because of there is a cavitation. You can see the entire anal verge till here. Incision is extended. You can still see clearly some source was left at 6 o'clock position, and that also taken, but there is no damage to the sphincter. This is the speciality of Sushruta's incisions. Okay, so you can still see the better. I will show you this videograph of this surgery. So you can see entire. So here median raphe is there. So this median raphe we need to leave. Median, he says sevani. You have to leave the sevani. Here 1.5 centimeter and here 1.5 centimeters. So this much you have to leave, and from here you can take, because this levator ani comes from here and forms the external sphincter like this. It comes like this and forms. So here you are not supposed to cut. If you cut, suppose if you cut here, that patient may go into incontinence. So taking that, Sushruta has mentioned, so you have to leave the sevani 1.5 centimeters both the sides, and then you can extend. And next is Suchi Mukha and Avanga Mukha. Antramukhe Sthulam Mule Anu Tena Suchi Mukham. So Antramukhe Sthulam. Okay. And Te Eva Avanga Mukham Adho Mukham. So one is a pointed incision. It is pointed outside, and as and how it goes inside and it is widened. And another one is wide outside and it is very pinpointed inside. So like that, when you do the Arshobhagandara, the cutaneous fistula, so that time these type of incisions, they are helpful. And while doing Arshas also, when you take an inverted V incision, so that time also this. So here, inverted V incision, it is very specific. So you need to cut less skin component unless and until it is inflamed and thrombosed. You have to spare the skin component because the enoderm, it is having lot of functions to do. So to spare, you have to spare the enoderm. So in that regards, this Suchi Mukha and Avanga Mukha, they help lot. So Arshobhagandara, so this kind of cutaneous. So here you can have this incisions. And then in 5th chapter, Acharya Sushruta has told Chandramandala Chedan Panipadeshu Karaye Ardha Chandra Kritim Chapi Gudameta Cha Buddhima. So it is a half moon shape for all types of anterior, posterior, high anal, low anal, transpinteric, intraspinteric, and single opening, multiple opening, all types of incisions. This Chandra Mandalavat Prani, this incision holds good, and it is very, very convenient. High anal, without damaging sphincter, you can enter inside the rectum, and rectal mucosa you can suture it. So like that, it is very convenient. Some of the cases, illustrated cases, I will show you. So this is another case where it seems to be very simple. It's only two openings you can see when dye is pushed, and incision was taken. Usually incision here was taken, and here it was not giving much clue. So here and here 2 incisions were taken, and you can see it is passing here, and one track, this was scooped out and sharp, and below that another track is there. So that also was excised, and here cavity, and it was going near to the capsule of the prostate. So this cavity was scooped out, Ksar karma was done, and you have to keep it open. So Foley's catheter was inserted so that it drains out. The cavity drains out. Okay. So this is how the final appearance of this Ksar karma and Ksar sutra and incision all were combined, and this was communicating here. So instead of cutting this one, so the primary threading was done and then Ksar sutra was applied. And to conclude, it's a very simple and less bleeding. You are coming across this very less bleeding, less pain, because you are not suturing it. Very less pain and no ugly scar. And thread sometimes needed, sometimes not needed. And if you are sure that you have removed all the track, you can suture the wound. You can suture them. And Ardhachandra Kritim se api Gudametra cha Buddhiman. So Ardhachandra Kriti incision, I call it as the king of all the incisions in among Bhaganda. And when you expertise these incisions and practically you practice, and there is no fear of incontinence, you can tackle the high anal fistula, multiple opening fistula in a single sitting. There is no double two sittings. You can single sitting, you can tackle, and it is safe to practice. So finally, post-operative patient is healthy, then patient is said to be healthy. Okay. So one must pass this tool. Patient must pass this tool, and then patient is said to be fit for discharge. Okay. What message you can take home? So Ksar karma is useful in cryptogranular origin. All the cryptogranular origin, because by doing Ksar karma along with the macro slough is visible. You can scoop out, you can pour out. Okay, so what we call it as mal suppression of this fistulous tract. But micro slough left over, again it may create the infection of cryptoanal glands. So when you do Ksar karma, all the cryptoglandular infected glands are destroyed, and then it is very helpful. Ksar karma is helpful in micro slough or removing the micro infection also. And after abscess drainage, to prevent fistula, you do Ksar karma. And always keep the open after Ksar karma. Don't suture it. If you have done only the excision of the this fistulous tract, you can suture it. Otherwise, don't suture. And with this, I would like to complete the PowerPoint presentation. But now I want to start with the videos. That one, the Sarvatobhadraka, which is the tough video, I want to show you. Sharing. Window. Pantanal. ಅದು ಫೋಟೋ ಇತ್ತಲ್ಲ. This is, I can talk now. This is one case. It was done in a modern surgeon's hospital. So, by looking at the fistulous tract and the cavities, that modern surgeon he told, so where to cut, what incisions to do. So I am confused. You better do it. So then it was referred by a modern surgeon, and then so only skin level we have taken the incision. We have not done it in. We have not cut the tissue. Okay. ಏನು ಟೆಕ್ನಾಲಜಿ ಮಾಡಿ ಎಲ್ಲ ಹ್ಯಾಕ್ ಮಾಡಿಡುತ್ತೆ. ಹುಡುಗ ಇಲ್ಲಿ ಇದ್ರೊಳಗೆ ಹಾಕಿಬಿಡುತ್ತೆ ಫೋಟೋ ಇದೆ ತೋರಿಸ್ ನೆಕ್ಸ್ಟ್ ಫೋಟೋ ಸಾಕು. ಅದ್ರೊಳಗೆ ಒಂದು ಕಡೆ ಹಾಕಿ ಫೋಲ್ಡರ್ನ ಎಲ್ಲ ಹಾಕಿ ಹಂಗಾಗ್ತದೆ. So meanwhile, you can ask questions and we can have a discussion. ಫೋಟೋ ಇಲ್ಲ ಇದೆಲ್ಲ ತೋರಿಸಲ್ಲ ಕಚ್ಚಿ. ಮಾಡ್ಕೊಂತೀನಿ ಎಲ್ಲ ವಿಡಿಯೋ ಫೋಟೋ ಇಲ್ಲವು. ನಂದಲ್ಲಿ Yes, meanwhile, you can ask me questions if you have doubts. Yeah. Question. For Dogre, it may be delayed due to poor network, but when opening anterior fistulous tract, it's a little bit complicated. Could you please explain your experience, sir, regarding that? Yes, this is a very good question asked. So I wanted to actually show you a video clipping of that anterior fistula. So anterior fistula in male, it is always a bit easy when you start doing many number of cases. Okay. So when you do number of cases, it becomes easy. Otherwise, it becomes tough for the beginner. Uh, so anterior fistula, you have to take a linear incision, and after that, when you come to this pincher part, then you make it curved or ardhachandrakriti. So that would be beneficial for damaging anterior fistula. You can tackle. So other questions? ಎಲ್ಲ ವಿಡಿಯೋ ಅದರೊಳಗೆ ಹಾಕಿಡತೀನಿ ಇದ್ರೊಳಗೆ ಇದಾಗುತ್ತೆ ಅಂತ ಹೇಳಿ ಒಂದು ಫೋಟೋ ಬಂತೀನಿ. So this is the you can see the post-operative that Parvatapadraka incision. What was the video clipping was shown. So this is what incision till from here till here, and it looks like this, and it's a healing process. Still patient is coming for the follow-up. So it is one of the tough case I have done, but healing is very fast, and still 21 days not over, and this much healing is there. Okay. Yes. Much better video. Video. Yes, sir. After completion of Kshara Karma, can we suture to reduce the surgical wound what has been exposed? See, Kshara Dagdaruna, Agni Dagdaruna should not be sutured. Okay, this is very clear. So once this type of granulation comes, what I have shown previously, so after 7 days or 8 days, you can do secondary suturing. You can do secondary suturing, but not immediately after Kshara Karma. It has to be kept open. You are not supposed to do suturing. When opening endless track, it's a little bit complicated. Could you please explain your experience regarding that? That I think I have answered this. Interior interior yes, isn't it sharing? This is one very peculiar. I show you this epistulous track. So from here, it is operated. Mute ಮಾಡಿ. ಇದು laptop, ಇದು video. Yes. So this the previously it is operated, and there is fibrosis and keloid like thickening, very skin thickening. And you can see very you have to push very gently. Dye, you are not supposed to push very with the force. If the extravasation of the dye is there, other than the track, if the dye is extravasated, what happens is while cutting or taking the incision, it becomes very difficult. You can see it is extending till here at the thigh. So this I will make it little fast, and then you can see it. So entire it is this, we call it as this incision, and then it is from once you take a linear incision and open it, and then treat all the branches. Okay, all the branches. So that you can call it as a Kharjura Patraka. So here you take the Ardhachandrakriti only. So here in the thigh, so this, and I have sent, I had a doubt that it is this kind of thickening and all. So I sent this one for histopathological report, and his histopathological report revealed that it is a chyluria. Okay, there was a thick, cheesy like material coming out from all the sinuses or the multiple branches. So that made to think that it is some different presentation. So it was sent for HPR, and it was a chyluria, and it was treated with a hetrazan, and all this thickening, keloid like appearance, everything it has gone after treating this. And such type of fistulae, there is no need of cutting. Better not to cut. Even if you cut, you are not going to do justice with the patient. Just you have done cutting and hardly you give the multiple openings, all extending, and there is, and it is extending, see, in the thigh region also. So how much you will cut, and what if you cut, and what will be left there? So better you take one middle incision and then lie open, and all the branches or the pores just with the cauterization you can, and then do Ksar Karma later. And in between, when there is at 6 o'clock, if something is left, and if the 6 o'clock it is opening inside the anal verge, you can do primary threading for that, and then later change with the Ksar Karma. It was 6 o'clock, there was an opening, and that was, and here the Kharjura Patraka was incision. Just let invert, camera is turned. Yes, you can say Ksar Karma was done. I'll stop sharing that. So I will show you another video. Innೊಂದು video open ಮಾಡೋದು. ಇದಲ್ಲ. ಇದು ಇನ್ಸಿಷನ್, ಇದು ಬೇಕು. sharing ಐತೆ ನೀ. Is this, you see this external opening here, and it is coming up to the, it is not opened in the anal verge, but it is coming till the 6 o'clock position, and from here the intersphincteric area, the anal crypt is infected. So that is tackled with this Ardhalangalaka incision. Okay, Ardhalangalaka, if it is operated previously, so bit fibrous tract will be there, and then it is bit difficult for the beginner. So one must understand the surgical anatomy of the anus and rectum, then it becomes easy. You can see incision. See, look at the incision here, only at the skin level, and probe is taken for the guide. Earlier I used to use the probe, and now probing is almost absolute. Huh? Stop sharing. Huh? ಏನ್ ಮಾಡ್ಬೇಕು ಹೇಳು? ಇಲ್ಲ. ಯಾವುದು? ಅದ್ರದ್ದು ಇನ್ನೊಂದು ವಿಡಿಯೋ ಇತ್ತು ಆಗಲ್ಲಿದೆ. This is one the Sharkarma was done. So you can see the track. It was excised, and then Sharkarma. You need not have to do Sharkarma in all the excised area. Okay. So this is the area where it is needed, the intrasphincteric area. And if it is not opening in the anal verge, you don't open in the anal verge, because the thick band of internal sphincter guards the rectum, so that the fistulous tracts do not open inside. Okay. And cleanse with the lemon juice. Yes. Simran Gupta. Sir, how we can know that which incision to be taken in which case? Actually, any case, which case? So I have with the video clippings. I tried my level best to show you the different incisions in different conditions. So only one thing I have not shown is the anterior fistula. Okay. So this I will show you the anterior fistula. Stop. Video stop. In home. ಈಗ ಶೇರಿಂಗ್ ಇಲ್ಲ. So I shall show you the anterior fistula. See the incision here. The linear incision is taken. Just you have to avoid the median raphe. Okay, you avoid median raphe and then take the incision. So it seems to be easy when you see somebody doing this. Otherwise, this type of anterior incision, it is time consuming for the beginner. So you practice your expertization under some experienced hands, and then you can start doing independently. So this is something it looks like when the cow passes the urine while it is walking. Okay. And equally, assistant also must be very uh, potent and active. And when you then you have to hold the fistulous external opening with the Alice forceps or thumb forceps, and from the posterior track you must start excising it. So you make a sufficient space for yourself, and always when you are dealing with the anterior fistulae, catheterization is very important. Anterior fistula in male it is easy, but for female it is a complicated fistula, because the anterior fistula, as you take now, this much space will not be there in female. So it causes, it may open inside the vagina, or it may open inside the what we call it as the bladder. So vesico-vaginal fistula or recto-vaginal fistula, they are a bit very complicated in case of female. So from posteriorly you must come, so that nothing is left. Okay, if you don't cut from the anterior, you must excise the fistulous tract from posterior, and the dye is your guide here. Okay, if the good cautery, you can use it, you can do it very fast. Okay, but it seems to be very easy when somebody is operating. If you go little deep, then at this level pelvic part of urethra comes. Okay, pelvic part of urethra comes, and sometimes I had to rush to the operation theater on table when there was urethra was exposed, and then Ayurvedic surgeon has some major role here. So then I was called 2 3 times when they exposed the urethra. So then I had to operate it. And you can see the anterior fistula. Somebody asked me the question. So I had a video clipping of anterior fistula. So there are different. And this is among anterior fistula, seems to be a very simple. But you get a complicated anterior fistula also. Anterior fistula complicated also you come across. So that time again you need a lot of experience and courage to excise. Sometimes when it is opening in the anal verge, you need to go for this pincer reconstruction also. If you want to do surgery, so you can do pincer reconstruction also. So for this pincer reconstruction, you need a different suturing material. Okay. So that suturing material is very costly. It is something, it costs about for single suturing material, it costs about 2000 rupees. Okay. So trade name, it comes like it is in the name this Monomax. It comes Monomax. And you must be very specific and very clear with the anatomy. So when you are excising, when you are cutting, we are doing the dissection. So where this pincher comes and what type of pincher comes, and then you must at the pincher level what you are supposed to spare the structure, what you are supposed to do. So they are very important. See, you have, meanwhile, you can keep on asking the questions. If you have, you can type and send the questions. So please comment about Windows technique in case of horseshoe fistula. So window technique, IFTAC. So they are also equally very good techniques. I don't want to comment on those any techniques, because when you are learning which technique you have learned, and when patient comes, or in which technique, in which surgery you are competent and you are confident, so that technique you use. If I am doing this technique, it is not necessary that everybody has to do this technique. So I believe in which technique you are confident, and which technique, which surgery you can perform very well without harming the patient. So whenever it is I have, since we are running short of time, I wanted to show you the videos. So why I directly came to this point, I modified my slides. The aim of treatment of this Bagandara is three types. It is divided in three. One is a medical management, another one is sphincter sparing, and another one is sphincter sparing, and another one is sphincter saving. Okay, sphincter saving and sphincter sparing. When you are doing dissection, you have to spare the sphincter. Okay, so like this, three aims you must have. So by doing you surgery, you treat the Bagandara, but even Bagandara may reoccur. It is not a problem. But patient should not suffer from incontinency of the stool. So by your procedure, there should not be incontinency. So that is very important. You keep this into your mind and then you do surgery. See, my assistant is very vigorous, very aggressive surgeon. So he pulled the track and then the track is broken. So then guide, next your guide is the die. So that you have to tackle with the next track, you have to tackle with the die. Any other question? Sir, just briefly explain sphincter reconstruction as you told with the suture materials. Yes, sphincter, see, so when you have a sphincter suturing material, so its absorption is 1 year. Okay, it is used for the tendon repairs or suturing the tendons, periosteum in orthopedic. So that we have utilized it for reconstruction of the anal sphincters. So when external sphincter, 1/3 you can compromise. Okay, 1/3 you can compromise. Suppose you are dealing with the anterior fistula and you have cut the external sphincter and the sphincter tonicity is lost and it is very very loose. So that time you can do the sphincter reconstruction. Just bring the sutures, bring the sphincters and together and approximate, and you by your two fingers you can assess the sphincter tonicity, and that tonicity you maintain and then do the reconstruction. Okay, so actually I don't have right now I don't have a video, and some other time if I have a video, then if I get an opportunity I can show you how this sphincter. Earlier I used to do some sphincter reconstruction before I practice Sushruta's incisions. So once I started practicing Sushruta's incisions, I don't find there is a need of sphincter reconstruction because his incisions are sphincter sparing incisions. We are not cutting the sphincter, we are slitting the sphincter. So it is really, I find a very wonderful techniques of incision by practiced by Acharya Sushruta. See, from above you came very linear incision you came. So when you came here, then you get stuck up here. Okay, it is, the track is very brittle. And then another question I have, sir, in case of fistula in ano, we have to manage or treat the primary focus. Then what is the role of shape of incision like Langalaka? See, you have to primary focus, that is a source, what you are focusing on. To reach the source, these are the incisions. Without damaging the sphincters, to reach the source, these are the incisions. Okay, that is one thing. Another thing is, when you take Langalaka incisions, both the sides, both the sides you can tackle at a time. You can tackle at a time in a single incision. So that is the beauty of Langalaka incision. To reach the source, to reach the focus, these are the incisions are the approach. To approach, the incisions are the tool for you. So now exactly I am on spincher level. So I am showing you it is in between, half is above and below is the external spincher. So now I slit the spincher, then cutting. I slit the spincher, then cutting. See, spincher is a muscular structure, so it is highly vascular and it bleeds. Yes. Mhm. So when open this method, this complicated track and excise all fibrous tissue, is it possible to suture? Yes, it is possible to suture. Fibrous, whenever there is a fibrous tissue, the fibrous tissue is a healed track. It is a healed track. If there is the dye enters the fibrous tissue, wherever dye enters, so that tissue you excise. Don't excise because it is adjacent to the dye or adjacent to the track. Okay, don't take. You can suture. You can suture. There is no problem. So when you have a confirmation that you have excised the entire tract. Suppose it is opening inside the anal canal. So up to mucosa you excise. Once you come to the mucosa, rectal mucosa, you clamp it. You clamp, you suture the rectal mucosa with the 20 white crepe. Remaining with monomax you can. So dye, wherever dye is there, that you have to excise it. I show you here. This is the external sphincter. It is here. This muscle fibers and here. It is exactly on the external sphincter itself. So then you can clean it with the normal saline or betadine, and then you see if there is some dye is left somewhere. So that tissue you can excise it. This is the dye, and this is the source from where we have started. And before you close or before you do Ksar Karma, you ensure that there is no bleeding. So this is the suturing at this pincher level. You can see somebody asked me the question of suturing. You can see how this pincher, this knot should go below. It should not above.
बेटा ये आगे कैसे बढ़ेगा? और ये
क्या आगे बढ़ेगा? ये कौन सी वीडियो लगा दी आपने? ये तो देख रहे थे ना अभी। कौन सा आगे बढ़ाना है? क्या कह रहे हैं पापा? पूछिए ना। पानी कौन है?
बेटा हमारे वाले में ये क्यों बन के आ रहा है इसका वो टोन का?
हेलो वो भी नहीं बन।
Whenever you suture this type of wound, you have to suture at 2 layers. Don't suture in a single layer. You see how the suture bites are taken, and this type of suturing, it ensures wound is very neat and it looks very nice. So single layer suturing and then skin level. And later scar, when wound heals, scar becomes a single line. This is how it looks. Then skin approximation. Now left is skin. Skin you can suture with a mattress. And these type of all, they need some time, patience, and wound heals. It heals very wonderful, and it looks very uh, neat, a single line scar. The median raphe is not affected. ಎಲ್ಲಿ? ಇದನ್ನ? See, it looks like this. When and it is sutured, it looks like this. Very neat, very comfortable, and healing is also very fast. And post-operatively, patient has to use commode. Commode. If they sit down in the squatting position, and what sutures you have done, everything goes in vein, and then everything will be wide open. Okay. Yes. For that, then they must use commode for 3 months. This is very important. And similar thing when the sphincter reconstruction is done, that time also same precautions they have to take. I think I have shown sufficient videos supporting the different incisions and suturing and closing also. So with this, I would like to conclude my presentation. Thank you very much, sir, for giving me this opportunity, a second opportunity at the plot for National SUSHRUTA Association. So thank you very much, sir, for once again. I am thankful to Harish Daga, Toshikane sir, Hemant Toshikane sir, and Hemant Kumar sir, and all other staff, seniors, juniors, and my colleagues for supporting me in this regard. I think yes, some questions are there. Yeah, questions are there. Shape of the incision, blah, blah, blah. Yes. Could you please tell what type of need for sphincter reconstruction? Yes, that Dr. Tilak Kumar, I told that specific sphincter reconstruction you require to suture the rectal mucosa. You need 20 Vicryl and Monomax urine, polygalactin. So that suturing material is polygalactin. So that on needle it comes, so that you can use it for suturing the sphincters. And yes, no other questions you can ask. If I am capable, I can answer, and otherwise, uh, my teachers are here, then they will come for my rescue.
కొంచెం sound, sir. I think
Time is,
Samudri,
sir.
I think almost you answered.
Yes, sir.
I think.
Yes.
Dr. Harish, any other questions?
Harish,
No.
No, sir.
no.
No, sir.
ಸರ್ ಇದೇ ಸ್ಲೈಡ್ ಹಾ ಅದೇ ಹೇಳತ್ತೆ.
I think almost he answered the questions. And first of all, I congratulate Dr. Samudri. Why? Because it is a really great task actually. And it's very important, you see, what our Sushuta Acharya, especially related Chaitya Bhagandar. Okay. In this concept, he nicely correlated with Sushuta's concept with the practical exposure, like maybe fistulectomy with what is called suturing method, or different types of incision he mentioned. But this is very important. Using these type of incisions needs some expertise. That is most important. Okay. And I really see whatever the surgery of fistula, different techniques are there. Different techniques: fistulotomy, fistulectomy, Ksharasutra therapy, Kshaраkarma, Tiftac technique, or laser therapy, or WAFT. So many techniques are there, but definitely there are some of the techniques. Their own limitations also is there, and definitely if you want to go for these type of techniques, you must need for expertise. Another thing is very important. He quoted that sphincter sparing. That is very important. You see, avoid sphincter damage. Okay, I think he operated a very nice surgery with totally, but needs continuous follow post-operative care properly. That is very important. And really appreciate Dr. Samudri with contribution of Sushuta's incisions. Really, also we tried so many in my thesis. This is the first concept started under the guidance of Manoranjan Sahuji, and we made some of the pictures. What you can see, Satapunaka Bagandara, like that, Ushtagriva Bagandara, like that. We made some of the incisions with correlating with Dalahana's commentary of different types of incision, branch incision. That is Karjura Patraka. Definitely, Karjura Patraka incision, you see, usually we practice it, especially the extension of the apsis. I think in what is called Fourniers gangrene. Fourniers gangrene, the ischirectal abscess, they spread to the up to the level of the scrotum. In Fourniers gangrene, we are going this type of incision. Like that, different places we used this incision. And once again, I really appreciate Samudri's views on the aspect of Sushruta. See, don't worry, everything is not following the single technique or thing. You must to know all the techniques. See what mentioned by Sushruta, they given different techniques in his textbook. Depend upon your expertise, you must to practice. And I think I concluded. And once again, I thankful to especially in the platform National Sushruta Association. We are together here. And I thankful to Dr. Hemant Toshikani, Harish Daga and their team, and Parul University for the giving this platform. And I request again, I think today also so many scholars, so many teachers, I received the registration in National Sushruta Association. And who are not registered, go for registration and can strengthening our association. Once again, I thankful to all the team.
Thank you.
Thank you, Samudri, and thank you, sir.